We're at the CROI in Boston, and we're appreciative that Carlos Del Rio from Emory University, who is also the chair of the HIV-MA, the Organization for Doctors in HIV. And we appreciate the opportunity to speak with you about some of the issues that you're faced with and wish to speak about and be an advocate for today.
Thank you very much. I really appreciate the opportunity. I think there's several issues. I think we can think about the global front and the domestic front and the international front, right? Mm-hmm. In the global front, I think we are seeing some gains, but we're also seeing challenges. We have now the mandate to treat everybody. We are looking to achieve 90-90-90. And the good news is we have 17 million people in antiretroviral therapy. The bad news, there's about 17 million people still to be treated if we're going to treat everybody. We have to scale up to reach the last 90. How are we going to know 90% are suppressed if viral load is almost not done anywhere? So we need to scale up viral load testing globally. We need to get more people into care. We need to change the models of care. I just came from a session talking about how can we make clinics more efficient? What can we task shift? What can we do in adherence clause? So changing models of care, differentiated care, and for that, this global response needs a lot of investment. And unfortunately, PEPFAR has been flat funded for many years. The Global Fund has been flat funded. Donor countries are not contributing as much. I'm concerned that when we had the Millennial Developmental Goals, HIV was one of the goals. Now in the new Sustainable Development Goals, the SDGs, HIV is not there. It's just one of the many goals is health. Health for all. Well, what does that mean, right? Mm-hmm. So I really think that we need to keep the eye on the ball, and we need to make sure that we finish the job that we started, and we don't take the foot off the accelerator at this point in time. On the domestic front, I think the challenges that we faced are we have to improve our models of care. We have to make sure that we improve our care cascade. The fact that we lose a lot of people in engagement in care is bad. The fact that only 30% of U.S. HIV-infected people are suppressed is bad. And we need to address the two issues that concern me the most, which is the ongoing epidemic and increasing epidemic on young people, particularly on young MSM of color. And also the fact that we continue to see increasing disparities in this epidemic. So more poor people, more disenfranchised people being affected. So again, we need to address social determinants of health. We have to make sure that we stop transmission. Having 45,000 new infections per year in our country is a disgrace, and we can stop that.
It means that there's a lot of infection out there, because if there's new infections, there is already a prevalence of infections.
Correct, and we have tools to stop it, right? We have PrEP now, we have other tools that we have to scale up, we have to implement. So I think we need to make sure that those things happen. We heard some very good presentations about PrEP, about how to scale up, about how to implement, but the uptake has not been as great as we would like to, and obviously we have a useful tool, we need to implement it.
Mm-hmm. So how do we move, what is the next steps? What would you say is the next steps to treatment or to scaling up?
Well, I think the next steps there are two things that are needed. Number one is we need to continue supporting research on finding a cure, research on finding better drugs, research on finding a vaccine, research on implementation science. Mm-hmm. We need to also use that data to inform programs, but we also need to really stop thinking about prevention on one side and care on the other, and really think about how prevention and care need to be integrated. And as you know, the challenge that we have in our country is that CDC does prevention, HRSA does care. How do we get those things to work together? How do we get those things to really be aligned? So prevention and care, we don't see this paradigm anymore.
Yeah, because the same doctors that are prescribing PrEP are also prescribing treatment. And there's no reason we can't have that.
And many times they're not. But the doctors working on, for example, on STD clinics, which are funded to do STD prevention, may not be able to do PrEP in the current funding structure. And we need to be sure that they actually, if they're seeing somebody with syphilis, they ought to not refer them to PrEP. STD clinics need to become PrEP clinics.
Right, exactly. It should all be the same. So this cascade of care would change. What about so that would be in our country. How would you see, what are some of the ways in which we could actually move into greater testing?
Well, again, we need more testing. We need more testing in both. We need to really make a reality the implementation of testing in healthcare facilities, particularly in heavily affected countries or heavily affected counties or heavily affected cities or states. We need to also offer more access to testing in harder to reach populations. We can't wait for people to come and get tested where we are. We got to get tested where people are. Mm-hmm. So we need to find out. We were talking yesterday about how you can use geospatial mapping to know where the epidemic is worse, and then you can direct your testing to those areas, right?
They did that in San Francisco, and it worked.
Right.
It seemed to work.
Oh, it clearly works.
Yeah.
I mean, targeted testing and following, geospatial mapping is very useful.
So the community viral load is what we're after. I know that I've seen some epidemiologists from or talked to them from different areas of the country. They said, we're not going to treat people just so that it'll reduce the viral load. And I said, this is the person who's the epidemiologist or the health officer for the community?
Nowadays you need to treat everybody, and the reason to treat everybody is
for their own good.
Well, yeah, exactly. It's a triple benefit, right? Reduces morbidity, reduces mortality, and reduces transmission. Mm-hmm. So the reasons for treating somebody today are threefold, and everybody needs to be offered treatment, and everybody has to be given the opportunity to streamline the process so they can start treatment without barriers and without difficulties.
How do we approach the communities who are less well understood or less obvious or invisible? Populations such as, we've had that issue in Florida with the older population who perceive themselves not to be infectable, when in fact they're having sex now because of Viagra.
Very hard, and unfortunately, it's an area that we need to continue to. We need to find who those populations are, and then we need to go and find them. We need to go to them. We need to work with, like we've done with every population. I think what we learned with HIV is we cannot impose things. We need to work with the community. Mm-hmm. So we need to find people in the community who are willing to work with us and be our advocates and be the ones that are driving the programs, mm-hmm. and then things change.
Mm-hmm. So what are your next goals? Are there any hot issues on the plate for HIV/MA?
Well, HIV/MA, as I said, wants to refocus on the Ryan-White reauthorization, mm-hmm. wants to focus on continuing support for global funding on AIDS for PrEP, for PEPFAR, wants to focus on PrEP scale-up, wants to focus on the workforce issue. We need to be sure we continue to recruit providers into HIV care. We have enough clinics. What happened in Indiana not only showed that there's ongoing transmission, but actually there was no clinic available, right? Mm-hmm. So this scenario of the country that has no clinics that can manage HIV, we need to start really focus on the growing epidemic of prescription drug use, of narcotic opioid drug use in this country that we're seeing, which created the outbreak in Indiana. Mm-hmm. Because what happened in Austin, Indiana is not just there. It's happening in other mm-hmm. sites. We're beginning to see mortality from opioid overdose in our country are going up in young people. Mm-hmm. So we need to address substance abuse. And we also need to really think about how do we ensure the next generation of HIV providers, right? A lot, patients with HIV are aging, but providers with HIV are aging. Yes. And we need to be sure that we have a strong workforce. Mm-hmm.
As we talked earlier, we are doing an interview with a number of young investigators. We, of course, encourage people to get into this field because it's the best and the brightest are going to be needed because it's the most complicated disease there is. But how would you look at, what would you say, do you have any policies at HIV/MA on scale up for PrEP in a divergent community? The country is very divergent in the way it might be needed in communities.
Well, HIV/MA is working with partners, working with CDC, with HRSA, working with our members mm-hmm. in facilitating, learning and implementing and scaling up PrEP. I think we're also working on at the policy issue and trying to really work with Congress and other organizations to increase funding for this kind of initiatives.
Okay, great. Well, I think you've covered quite a bit, and I appreciate your taking the time.
I appreciate the interview, and again, thank you for taking time to meet with us.
We've met with a lot of other chairs of the HIV/MA, and we always appreciate the work that you do now and they did in the past. So
it's a great organization, and again, that really wants to work for both providers with HIV, who has over 5,000 members, but also at the same time, our focus is on patients with HIV and improving the life and quality of care of people with HIV.
Thank you very much, Carlos.
Take care. Thank you.